No, Beverly. Very good. Hello, everyone, and welcome to the first grand rounds of our academic season for SSAT Complex GI Surgery Fellows. My name is Annie Benzie. I am the co-chair of the Fellow Subcommittee for this. And we are so excited tonight to have a fantastic topic, which I'm sure we'll get into a little controversy because it is a little bit nuanced and also new when it comes to surgeons adapting for intraoperative protocol. So without further ado, I would love to introduce Dr. Michael Ojiki, who is the chair of surgery and vice chair of surgery for innovation and program development, chief of gastrointestinal and general surgery, and director of minimally invasive surgery and surgical simulation at North Shore University Health System in Evanston, Illinois. Dr. Ojiki, we're so thrilled to have you tonight. And if you wouldn't mind, if you could just start us off and give us a little overview of this topic.
Well, I think this is exciting technology. It's been around since about 2012 or so, and originally was really thought to be used just for diagnostic uses. For example, diagnosing esophageal motor disorders like achalasia, for example. But we started using it in the operating room about 2012 because we felt like this might be a device that could tell us how good our hiatal hernia pairs are, for example. It also can be used to tell us whether or not our myotomies are complete. And over the last 12 years, and with about 2,000 intraoperative patients, we have found that indeed it can give us kind of an ideal range in which we can shoot for when we're doing surgery. And so I think this is technology that, in my bold opinion, I'm going to say is going to become standard of care within the next 5 years for any foregut surgeon. But as you mentioned, it's still the data collection. It's really taken us this long to be able to get long-term results. You know, can this predict recurrence rates, for example, for a hiatal hernia pair? Well, we have found it can. Can it predict dysphagia or gas bloat? Well, we have found it can, but it took years to really, and many, many patients to really be able to come up with those answers. And I think we're going to hear a lot about those here from Dr. Lee, and I'm excited to listen and have a discussion about it.
Perfect. Dr. Lee, floor is yours.
All right, thank you both. Thank you, everyone. And here we go. So my name is Benoit, and I'm a current fellow with Dr. Jayaraja in the Methodist Richardson Medical Center. And my topic here is EndoFlip and its application. And first of all, it's the SSAT. And our mission is to lead in advancing the science and practice of GI surgery. The SAT is a global community leading the future of GI surgery through innovation, research, advocacy, and dissemination of knowledge to advance clinical excellence. We value education, scholarship, discovery, and innovation, quality clinical care, leadership, meritocracy, and interdisciplinary collaboration. We encourage you to join and become a member, and if you haven't, and I have no conflict interest to report. So today I'm gonna start two cases. These are two recent cases we did. The first one, the 85-year-old lady, she had a history of a recent STEMI status post PCI. She presented to the ED with obstructive symptom. She was diagnosed with hiatal hernia with gastric volvulus, but due to her recent PCI, this was managed with conservatively with NG decompression. Fortunately, the follow-up after GI showed no obstruction. We discharged her on liquid diet with a plan to repair the hiatal hernia electively. And naturally, the question is, how can we decide if the closure is tight enough or too tight? Second case is a 39-year-old gentleman without past medical history. He presents with progressively worsening dysphagia to both liquid and solid. So he underwent pretty extensive workup, including CT scan, alpha GI, EGD, and manometry. Yeah, manometry confirmed the patient had a type 2 achalasia. We recommended robotic hilar myotomy. And the question is, I mean, how can we decide if the myotomy is adequate? And okay, this is the content of our my talk today. I talk a little bit, introduce a little bit about impedance planimetry and EndoFlip, and discuss several applications, both diagnostic and therapeutic. And then we will have a good discussion later on. So impedance planimetry, I mean, is a technique developed in late 1980s to measure the diameter and the pressure of a lumen of a GI tract by distending a plastic bag. And then on the left side you can see there's a simple, I mean, very simple probe, only have one um, set of excitation and a sensor, and then just measure one CSA or cross-sectional area of this bag. And this obeys the Ohm's law, and it said that if we fill a bag with a ceiling and pass a constant current through it, the CSA is inversely proportional to the voltage across the sensing electrodes. Actually, I mean, later on, and people place more multiple sensors, I mean, in one probe, and can measure multiple CSA simultaneously. I mean, here on the left upper, you can see the probe capable of measuring 8 CSA at the same time. And actually, this can be used to profile a sphincter region. The lower figure show the data, the raw data from the 8 CSA measuring during a back distinction. And you can see here, the data, I mean, quite difficult to interpret. And if we apply some mathematical algorithm, I mean, the data on the left lower can be transformed to a 3D dimensional diagram showing on the right side. And even better, it can display the dynamic variation during installation. And now it is officially called the impedance luminal imaging probe. And also, if the probe is long enough to cover the majority of the majority length of the lumen, like esophagus, a flip panometry can be generated here, like a high resolution manometry. We can see some contractile patterns here. So for example, A is a normal subject. It shows like a repetitive antegrade contraction with the normal EGG opening, esophageal gastric junction opening. So B shows that no contractile response at all, but with normal opening. And C here, you see there's an impaired, disordered contractile response and reduced the EGG opening. And this patient actually has a type 2 achalasia on manometry. D, similarly, you can see that a spastic reactive contractile response with sustained occluding of the EGG. This patient has type 3 achalasia. So what's the difference of high resolution manometry versus EndoFlip? I mean, exactly 2 weeks ago, Dr. Yujiki and Dr. Carson did a webinar on surgery on. I fortunately attended that webinar, so I stole some slides from this slide from Dr. Carson. He says the high resolution manometry is performed when the patient is awake to measure the response to active swallow and primary peristalsis. It records the lower esophageal sphincter relaxation and the GEG junction, GEG pressure. But EndoFlip is performed when the patient is sedated and measure the response to sustained distension of the bag. It checks the secondary peristalsis. It's a contractile response to distension. And it shows the EGG distensibility or the EGG opening to pressure. Here is the most commonly used flip system, the EndoFlip. Uh, Here you can see, I think everyone probably already use this already. So the probe consists of a 24 centimeter times 3 millimeter catheter with a highly compliant a bag, a balloon attached to the tip, surrounded with 16 pairs of impedance electrodes mounted on the catheter, and then there's a solid state pressure transducer on the distal end of the catheter. So the shorter one, there's two type of catheter. The shorter one, the 8 centimeter EF325, it can provide the information regarding the EEG distensibility and the CSA, whereas the longer one, 16 centimeter EF322 catheter, can provide esophageal body secondary peristalsis pattern, like to generate a panometry in addition to the EEG metrics. Well, I will play a short introductory animation by the from Medtronic. Okay, so now I think a majority of the hospitals are OR equipped with the EndoFlip 3 instead of 2. So here are the number. Here are the parameters that we can get from a routine EndoFlip test. The one is the diameter. The second one is the pressure, and then the third one is the CSA, a cross-sectional area. And lastly, and probably the one of the most important one is the distensibility index, or DI, which is the ratio of the the CSA to the distension pressure at each distension volume. So DI has been recognized as a metric used for diagnosing disorders with impaired lower esophageal sphincter relaxation or mechanical obstruction at the GEG. So as I mentioned earlier, we can also use EndoFlip to obtain contractile patterns. Here, the 1, 2, 3, 4. I will talk a little bit later. This, yeah, this is another few examples, similar like the slide I showed earlier. So A is a normal one, showing a repetitive antegrade contraction. B is in achalasia, there's no contractility. C is a EGG outflow obstruction, showing repetitive antegrade and repetitive retrograde contraction. So again, Doc Carson's group, they measure they study the normative value of flip panometry, and they concluded that the EEG DI above greater than the normal parameter or EEG DI at 16 millimeter is above 2.8 with a median of 5.8, and distendability plateau greater than 18, and the presence of the RAC, repetitive antegrade contraction. A similar study, well, not similar, this is another article investigating the normative value of DI. This is a meta-analysis article representing a 115 normal subjects. So instead, they recommend DI at 2. So they recommend using a cutoff of 2 at 60 millimeter for clinical practice. The values below 2 can be considered abnormal. So yeah, so for this flow chart of Chicago classical classification in version 4, so actually flip
I'm sorry,
here.
Ben. I'm just going to interrupt for just a second because, Mike, I think before we get to the specifics on this, could we just agree that the things that you're looking at are going to be distensibility, diameter, and length of sphincter? I just want to make sure that the audience captures those three major elements because not everyone may be, aware of this. So Ben, you did a great job of outlining this, but I just want to stop for just a second and make sure that we capture those three key components. Mike, you want to comment?
Yeah, I think for diagnosis, the two most important parameters are diameter and distensibility index. So if you're trying to diagnose somebody with either achalasia or EGJOO, or just a normal, sphincter, then those are the two that you want. In the operating room, we do have the advantage of being able to measure the length of narrowing. But honestly, I think we do a pretty good job of that already surgically. So I don't even feel that strongly that the length, we need to really be strict about it. When we look at our own data, we fall within that range most of the time. And so I don't even worry too much about that. I think if there's one thing as a surgeon that you want to pay attention to, it's a distensibility index. So I totally agree. There's another component that is on there that really was meant to look at the kind of the bolus going through there, but really no one's really looked at that in a lot of depth. And I think just going forward, the distensibility index is the easiest thing for us to look at. Absolutely. And I think, the important thing that he just mentioned was that only 5% of the normal population has a distensibility index less than 2. So if you are measuring and you have a distensibility index less than 2, then that is most likely a non-relaxing sphincter, or it could be, related to a hiatal hernia, like a kink in the anatomy. So if you see a distensibility less than 2, you either have to, number one, you have your diagnosis, or you have to make sure the catheter is actually working. If it is post-operative, then you have made things too tight. And then the only other thing I would mention, because there's, I think, a lot of confusion around this, is that there are definitely people out there that are measuring the distensibility index with an insufflated abdomen. And if you do that, then these numbers are totally off. The numbers that he just presented are in patients that do not have an insufflated abdomen. And insufflation will lower your distensibility index anywhere from 0.5 to 1. So, whereas we say that maybe a distensibility index of around 2.5 to 3.5 is ideal, that's in a non-insufflated abdomen. If you're doing laparoscopy or robotics and you have an insufflated abdomen, that 2.5 to 3.5 is not the right range. That range is a little bit higher than what you would see with an insufflated abdomen. We recommend that these measurements be done with desufflated abdomens, because they're more likely to then correspond with what GIs might see in the GI lab when they have a non-distended or non-insufflated abdomen. And that's why all of our measurements are always in a desufflated abdomen. So hopefully that helps.
So you completely release the pneumoperitoneum.
That's correct. We stop insufflating and we let all of the air out. We look at the pressure, make sure it's down to close to 0, maybe 0 to 3, and then we take our measurements then.
Okay, thank you. I can continue mine. You see, I think the author here, the consensus is that when the patient presents with dysphagia and has an inconclusive diagnosis of achalasia by the high resolution manometry, the author recommends to perform a timed bearing esophagram and or a flip, so that can make a diagnose or a denied diagnosis of a EEG OO. So in the flip has been shown to a highly sensitive in recognized motility abnormalities. I have shown this picture several times, but look at the right side. Like Dr. Yujiki mentioned that any number below 2, well, definitely below 2.8, most like the patient had a major dysmotility disorder, either achalasia, EGJ00, or other spans jackhammer. Probably we don't use it anymore. But yeah, this is the case. And then this slide shows the relationship of flip panometry and the manometry motility classification in patients with esophageal dysphagia. So when the patient has a normal flip, and then there's only 27% of a chance of having a major motor disorder. But if the flip is abnormal, and very likely like 66% of the chance the patient may have a major motor disorder. And the treatment, the application of EndoFlip in achalasia treatment, and that's what we want to see. Here, this is a study showing that both CSA and distensibility can be progressively diminished from healthy volunteer to successfully treated to unsuccessfully treated and newly diagnosed. And you can see we can use this data to see how the successfulness of a treatment. And for patient after treatment, if the patient had a normal distendability, usually this group of patient had better swallow than a patient with impaired distendability. I think this study used 2.9 as a cutoff value. Okay, next I'm gonna talk about flip and GERD. This study show the representative picture photo on this on one controlled subject and one patient with GERD. You can see the hourglass, the shape of the hourglass is quite different, and the waist of the hourglass is wider in GERD, and also the pressure here in each volume distinction, the pressure is much lower in GERD patient. If we put them together, you can see the distendability in GERD patients is here
If it's
significantly
okay,
higher.
if it's okay to
Yeah.
interrupt you, I wouldn't
Yeah.
spend too much time on Flip as a diagnostic tool for GERD because it really has been found not to be accurate. There are people that have a fairly normal distensibility index with very severe GERD. And so unless the distensibility index is extremely high, like for example, over 10, then it really isn't really it won't tell you whether or not someone has GERD or not. It's not a great diagnostic tool. So I think it's okay to show some of the data, but I wouldn't spend too much time on it as a kind of a diagnostic tool for GERD.
Could we just expand a little bit on the question in the chat too? What's the difference between EGJOO versus having a hiatal hernia, and how exactly do you counsel those patients? I guess is a question too.
Yeah, that's a good question. So I came from a fellowship with Christy Dunes and Lee Swanstrom where we would really and I still had continued until recently to get a manometry on everybody preoperatively before any anti-reflux surgery, including any kind of hiatal hernia like paraesophageal hernias. And there are times where we will see on manometry EGJOO, and we really don't know, is that truly a lower esophageal sphincter problem, or is it the hernia itself that's causing the manometry catheter to think that there's a non-relaxation of the sphincter, like a kink. And that can be difficult. So now we have a device that tells us. So if we didn't have this, it might be a little bit scary in those patients because we probably would just have to do a myotomy or not. But we really wouldn't know, and we would be watching to see how they did postoperatively. Well, now we have a device that tells us very accurately whether or not there truly is EGJO or not. But what we'll do is we will actually start the hiatal hernia repair, the crural dissection. And once we have 3 centimeters or more of esophagus intra-abdominally, we will then put the before we do the crural repair and before we do any kind of fundoplication, we'll put the catheter down and measure the LES. And I will tell you that 8 or 9 times out of 10, it will be normal, meaning it'll be a sensibility index over 2. But once in a while, you will truly have EGJOO and a large hernia. And in those patients, we've reduced the hernia, we've measured, it's still tight. We will go forward with a myotomy in those patients. And I will have already told the patient about this when we have that manometric finding of EGJOO and a paraesophageal hernia, for example. I will counsel those patients, just like I said, most likely this is just the hernia causing that. But we will measure. We have a device that will measure that when we're finished, dissecting out your hernia. And if you truly do have this phenomenon of EGJOO, we'll go ahead and do a myotomy and a partial fundoplication. Does that help?
So can I ask then, do you avoid manometry now in the preoperative setting? Because I have to tell you, that is the test that every patient hates the most. And so,
So,
like you, we
yeah.
kind of avoided that, especially in the era of Toupet as opposed to Nissen. I feel like this may be something that we really need to emphasize on this call. So could you just elaborate on that? And my second point is, you're a lap guy, Mike. For those of us doing robotics, it's a real pain to desufflate completely. So I drop the pressure and use that as my measure. I gradually drop it, but to undock and completely desufflate is really painful.
Yeah, I know. And I think, we have a couple of kind of white papers, if you will, coming out similar to the Chicago class for manometry. We've started a kind of an EndoFlip class, if you will. We're not naming it that yet, but there's a publication that I hope to come out soon in the Journal of Foregut that will kind of outline, the ranges that we should be looking at and the outcomes there. And I think again, if you shoot, if the ideal range is about 2.5 to 3.5, but if you're not going to desufflate, then you're going to want to shoot about 0.5 to 1 lower than that. So you'd be looking at, anywhere between 1.5 to 2, and to what, 2.5 to 3 or so. So 1.5 to 3 would be kind of your new range, I guess, if you're not going to desufflate. And I think that's fine now that we know the difference between the two. But I think using our ideal range that we have found with insufflated abdomen will be incorrect. That will be too loose in an insufflated abdomen. I think does that answer your question? What was the other question that you had? Oh,
Role of
manometry
manometry.
pre-op. Yeah, I will tell you that we are now infrequently getting manometry preoperatively, and the only times I'll do it is if we still get an esophagram. I still think an esophagram has a lot of value. There are people that are sent to you rarely, but sent to you with the diagnosis of a paraesophageal hernia that actually don't have a paraesophageal hernia, but have maybe a large esophageal diverticulum that mimics a paraesophageal hernia, on endoscopy or other means. So even a CT, for example. So we will always get an esophagram in our patients. And if there's any evidence of achalasia or EGJOO on that, we might get a preoperative manometry now. But most patients now that that we're confident don't have achalasia or EGJOO, we will just take them to the operating room and get our measurements there. And we do get panometry, meaning we want to understand, and most people, if possible, whether or not they have dysmotility or normal contractility. So we will do that at the beginning of the case, right after intubation. But the important thing to know if you're going to do panometry in the operating room is that you have to do it under total intravenous anesthesia, which basically means propofol, because most of the anesthetic inhalation agents like sevoflurane, which is commonly used, inhibit esophageal peristalsis. So if you have gas going, which is what the typical general anesthetic will use, you cannot measure esophageal contractility. It's going to be, there'll be none. So our anesthesiologists are used to just doing TIVA, total intravenous anesthesia, for the first 10 minutes of the case. And then as soon as we get our panometry readings, we prep the abdomen, go scrub and do it, and do the case. And our anesthesiologist will switch from TIVA back to inhalational agents. So that's one thing that's important. But I will also tell you that ideal range that we have been talking about of 2.5 to 3.5 is the same whether or not a patient has normal or motility or dysmotility, as number 3 there on this slide shows. And that's a really big deal because that means you really don't have to know the patient's motility status preoperatively. I think it's still nice to know it, and that's why we get panometry, but that's more so, I guess, so that we have it if the patient is having any issues postoperatively, we can at least say that we understood their motility preoperatively, but it doesn't change your management to know that. So if you wanted to skip that altogether, the only really important thing to then know is, does the patient have achalasia or does the patient have EGJOO? Because in those cases, you don't want to just do a fundoplication without a myotomy. They will be worse. And so you don't need to know the contractility. And all you have to do is use a short balloon, the 8-centimeter balloon, and get the distensibility at any time. And you don't have to worry about anesthesia. They can, the anesthetic agents don't affect the LES relaxation, just the motility.
Amazing. Thank you,
Okay.
Dr. Lee. Want to continue?
Yes. Okay. Now we are done with the with girth. I think I only have one slide on this flip and the eosinophilic esophagitis. Since as surgeon we don't treat this disease often, but it can be, I mean, flip can be used to help with the diagnosis, to check to measure the effectiveness of treatment, and to check the severity of the disease. So the next one application is on the pylorus. So similarly, um, the flip means pylorus is also a sphincter, and we can use the flip to check the diameter, to check the pressure, and to measure the effectiveness of a treatment. Let's see. Here. So here is the assessment of a pyloric sphincter using EndoFlip. There's a medication here, hyoscine, is not available in the United States, but outside United States, it was used for esophageal spasm, abdominal pain, distension, and it's an anticholinergic medication to relax the smooth muscle. So you see here, in the flip, we can check the pressure and also the distendability. So once inject some relaxation agent, hyoscine, and the distendability increased in pylorus. And this is a flip and the gastroparesis. This is a representative picture showing health volunteer, gastroparesis patient, and a patient with after esophagectomy. You see the waist of this hourglass is narrow, and also similarly the pressure and the compliance or disability, distendability, the lower in these two group of a patient. And one surgical treatment for gastroparesis is the GPOP. And I think I have here, here you can see, I mean, after GPOP, so the CSA is significantly enlarged. Uh, but surprisingly, the pressure or DI didn't change much. But after some time, if the patient is successfully treated uh, by GPOP, GPOM, and the CSA, both CSA and the DI, I mean, increased when compared with the clinically failed patient. Uh, yeah. So the author, I mean, argued that yeah, the flip can be used to intraoperatively to see the effective the myotomy. Lastly is another catheter called EndoFlip. Pretty much you the EndoFlip balloon as a dilator, and they said it the potential advantage of EndoFlip include the ability to dilate over a large range of diameter with one balloon in controlled manner, and the potential to avoid the fluoroscopy and radiation, and the ability to assess esophageal dimension before and after treatment. So far, I haven't seen any our surgeons or GI use this. Okay, this is the conclusion of my talk. This is the AGA guideline regarding EndoFlip. It's the most updated in 2017. Probably we will need a new one. But well, here we go. So best practice advice one is clinicians should not make a diagnosis or treatment decision solely based on FLIP. Second one is FLIP assessment is a complementary tool to assess GEG open dynamics and stiffness of the esophageal wall. Advice three is utilization should follow distinct protocols, like Dr. Ujiki mentioned earlier. Advice four is clinicians should not utilize FLIP to routinely diagnose assessment of a GERD. And advice five is FLIP should not be used to diagnose eosinophilic esophagitis, but may have a role in severity assessment and therapeutic monitoring. We look forward to Dr. Yujiki's paper soon. So the case concluding, I have a case one, the hiatal hernia lady with the gastric volvulus. So we closed the crura with Acibon, and then we decreased the pressure to 8, and then we depressed intra-abdominal pressure to 8, and then we performed the EndoFlip measure. The distendability was found to be 1.5, and the GEG junction diameter was found to be around 8 millimeter, and it was 3 centimeter in length. And then since the hiatus defect is quite large, so we put a heart-shaped physics mesh to reinforce the repair. For the achalasia patient, the myotomy was performed on the distal esophagus and proximal stomach. We performed an EED to confirm there's no residual stricture or narrowing, no leak either. And then we performed EndoFlip, and we found the distendability was 1.4, and the diameter was 10.4. Well, thank you for your attention. And
Dr. Lee, can you put that, go back to that slide again? The only thing I would point out, and you said it earlier, you showed the data, less than 5 or only 5% of the population has a sensibility less than 2. But both of these patients left the operating room with a sensibility less than 2. So, these are patients now, if this was a desufflated abdomen, these patients would be more than likely to have some sort of either dysphagia, or in the case of the first one, a gas bloat. So I would not recommend leaving the operating room with the sensibility index in those range. Now, however, it sounds like you still had some increased insufflation. So you said 8 for case 1 and 10 to case 2. So in those cases, then probably these numbers are okay. But I think we have to be very careful about making sure that we are, when we're talking or when we're writing about our outcomes, that we specify whether or not we are using insufflation or not, because 1.5 would be too low in a desufflated patient. That we just said that's achalasia actually. That when you get under 2, you start thinking that the patient has either achalasia or EGJOO. And I would not recommend leaving the OR with a patient with a desufflated abdomen and a flip number like that.
Yeah,
then,
Mike, I think you bring up some really good points over there, and I think you're absolutely right. And we do these robotically, so we do drop the pressure from the beginning of the case for a couple of reasons. One is capnothorax issue reasons, and also for issues related to EndoFlip. We generally, on the achalasia patients, get a measurement pre-anything. At 8. And so we have a pre-measurement. And one of the things that I think is probably important to emphasize is I do think the change in distensibility is an important number also, not just the absolute number. And so, because as you know well, different patients will have different distensibilities, but different symptom complexes based on that. The other thing that I think is most remarkable too is also the length of the sphincter. And I think that I know we may not understand this completely, but I really think this is an important parameter. And so I think that this is something. The other thing that I just want to say in full disclosure, we don't use mesh in our patients mostly, but because I thought, gosh, this was, I thought, going to be the most contentious point of these two cases here. One of our group uses, we as a group will occasionally use mesh in very, very specific circumstances, but we've really moved away from using mesh. And just to say that in our crural closures, we will always close posteriorly. We will never place an anterior stitch because that to us means we have not performed enough transmediastinal dissection of the esophagus at least in our opinion. So I just wanted to make those comments because you're completely right that these numbers are a little low. But we do, and I don't think Ben showed the pre-numbers, but we always want to make sure that we are changing in the direction that we want to for reflux and for achalasia. Does that make sense?
No, it totally makes sense. And let me just say again, I mean, they're low if you didn't have any pneumo or capnoperitoneum, but it sounds like you did. So these numbers are probably actually right at the low end of normal or low end of where you want them to be, but you just still had some capnoperitoneum. And so I think the numbers are acceptable, but we just have to make sure that we're always letting people know and documenting, for example, in your note, you know, the
Yes.
detectability is 1.5 insufflated, you know.
Absolutely. So we always kind of bold that in our note and say
Yeah.
at 8 millimeters, paragraph 20 cc's this, 30 cc's this, 40 cc's this, and then post at 8 millimeters, boom, boom, boom. So I try to do that, not only but for research purposes too, because we're looking at that.
Yeah.
So thank you.
And I
Sorry.
think just to respond to the chat, you know, from Dr. Benzi, I think the nice thing now is with more surgeons doing endoscopy, and certainly if you're a surgeon of the foregut, I really think you need to be doing endoscopy regularly, both in and outside of the OR, but specifically inside the OR. But now you have a device too, and this is really important for people who are practicing maybe in more rural areas or have less access to manometry, for example. You actually now have a device where you could do your comprehensive workup could be done in the operating room at the time of surgery. So like a patient that you brought up that maybe hasn't had an endoscopy in a couple of years, I will do the endoscopy, but I won't make them go do a separate procedure. I will just do it at the beginning of the surgery. Before we've done anything, just to make sure that there isn't, I mean, basically you're looking to make sure they don't have any major pathology like a tumor or a big precancerous something that might even be inaccessible after you do your wrap. But you can do that at the beginning of the case. And I always warn the patient, there's a very slight chance, maybe less than 5%, that I may do the endoscopy and find something that would make us abort doing the case today. But, you know, if you prefer, you could have a separate sitting where you do an endoscopy either with your GI doctor or myself, or we can just do it in the operating room with the caveat that there's a small chance that we might find something. And almost every patient is like, please just do it. And I'm okay if you find something, we'll you know, we can reschedule the case and we can wait for the pathology, blah, blah, blah. But now we also have a device too, where we can avoid manometry in most patients. And I agree with the comments being made. If there's any suspicion that there might be you know, a lower esophageal sphincter issue, you should absolutely still get manometry ahead of time so that you really have the answer and then can, you know, put the patient in the right, you know, OR situation or the right procedure. But, you know, given that most patients, and we all know the data that preoperative manometry in an anti-reflux patient shows achalasia 1% of the time. So really you're doing all of the manometry to maybe diagnose 1 or 2 patients in 100 that are going to have something that truly changes your management. So I think it's completely reasonable to do an endoscopy at the beginning of the case under TIVA or total intravenous anesthesia, do your EndoFlip and panometry, and you've got your workup in one sitting. How convenient is that for the patient? All under sedation and comfortable. I am a big pre-op manometry proponent until now, and so I know that there are a lot of people out there that would argue against doing manometry in the pre-op patient. And I always took the side of we want to know, and we want to make sure that we don't wrap somebody that has achalasia or EGJOO. But now we have a device that can do that without putting the patient through multiple trips to the hospital. Certainly in the case of manometry, an uncomfortable test because you're awake. This is a great device to have. And I think a lot of us are working at places where we have everything at our disposal, but there are people out there that don't. And I think even more important for them, you've got a device that can help you.
So,
Excellent.
doctor, what's your thought of doing routine partial wrap? Like
Well, I
to
think a
not
few things. Yeah, I think that's a good question. We have not performed a Nissen fundoplication in about maybe 4 or 5 years. And that was completely based on the randomized data out of Europe that showed that, Toupet had equal GERD control with less side effects. Having said that, though, we presented at DDW at SSAT actually this year in May. The paper is almost done. That if you compare Nissen and Toupet in the same distensibility range using EndoFlip, you actually have the same outcomes. So for those people that are big Nissen proponents, you're not wrong. You just better make sure that you're doing the Nissen correctly, meaning that you are leaving that patient in the right distensibility range, because I do believe, and now this is just my feeling and opinion, that the one advantage of a Toupet over a Nissen would be that the patient probably still can vent easier if things are tighter than a Nissen. If you have a Nissen that's outside of the range, they will do worse than a Toupet. But if you're in the ideal range, they should do just as equally well between the two. So I'm not against Nissen fundoplication by any means, but we just really have we've had good results with a partial or a Toupet fundoplication. And in the end, I'm not sure the fundoplication, as long as it's done correctly, matters as much as making sure that the crural repair is performed well. And so I think that people can argue about Doors and Watsons and all these different types of fundoplications in their own little personal ways, and I think that they're all correct. I don't know how much of a big difference there is in my opinion, but I think the crural repair is very important.
Dr. Hayek, would you like to expand? The question about needing to do a fundoplication versus just PEXI after crural closure.
Kevin, you sent a paper in the chat.
Yeah, so I do defer now about 40, probably 50% of the time once I do hiatal closure. So I do defer fundoplication altogether.
And that's what we've been doing, Kevin. I think this is a really good point. I mean, one of the things, Mike, is every redo, which Annie can tell you and Ben can tell you, is about 60% of my practice are redos. If every redo has more problems than any primary refluxer. And it's usually because there's some sort of slip around that wrap. Just a straight hiatal hernia wouldn't cause as many symptoms as a problem with the wrap. So we've actually moved towards primary crural closure, looking at EndoFlip to guide that, and gastropexy, because they always recur on that left side, if you notice. And so a nice cruroplasty to that. I've lived through G-tubes and all sorts of configurations of pexis that I hate, but ended up with this kind of gastropexy to the left diaphragm. I wanted your thoughts on that, because I really actually have begun to feel fairly strongly about this, that a failed fundoplication is worse than no fundoplication.
I think you're absolutely right. First of all, I will also say that I don't believe that fundoplications slip after the surgery at some point. I think that those fundoplications were performed on the cardia of the stomach at the time of surgery. And one of the things that we always do is intraoperative endoscopy and identify the GE junction, not the Z line, but the GE junction. We identify the GE junction endoscopically. We mark it with a marker laparoscopically, and then we know now that we want to keep our fundoplication above that line. on the LES, because there's no question, Rohan, you're exactly right. People that have a poor fundoplication are way worse than without a fundoplication. And I think you're hedging your bets when you do just a gastropexy. I think that the data still, I think we need data, and I think Christy Dunst is leading that with a multi-center study looking at, fundoplication versus no fundoplication and just gastropexy. And I'm anxious to see the results of that, to see what it's like. But I will say this, when we look back at our data with EndoFlip, we have found that the majority of patients have a distensibility index in the normal range, even with reflux and even with a large hernia. And so, do you need to make it tighter when it's already in that right range? And I think that's what you're all getting at. So I think we have to make sure that our crural repair is correct. And that's most important, but I think it's still up to debate whether or not the fundoplication is necessary. I will tell you that my hunch is that I think a well-performed fundoplication is maybe still going to be useful, because I think we've all had a patient that we have performed just a crural repair that has come back with reflux. But we've also had patients with fundoplication as well. So that's why we need the data. But I think there are some people, and when we measure the LES, there are some people that have a pretty wide open LES. And so if you just close the crura, is that enough? I'm not sure. So I think maybe we can use this to guide the decision to even do a fundoplication. I think that's where, that's a possibility, is that if somebody has a super high distensibility index, then maybe we should be doing a fundoplication. But if you reduce the hernia and you measure and their distensibility index is 2.5, do you need to do any more? Just close the crura and get out. I think that's very a real possibility there. And Kevin has, shown that with his own data. And I think you have too, Rohan. So I think it's reasonable to think that.
And Dr. Cho, with our final questions, any data on Belsey Mark 4 fundoplications, and is a posterior gastropexy after hiatal repair basically a hill repair?
We personally don't have any data, and I don't know of any data on Belsey Mark 4. I've looked through it recently, and I don't remember seeing it. So I could be wrong, but I don't know if there's any flip data on Belsey Mark 4. In terms of posterior gastropexy, I think that's not a hill repair by any means. I think when people refer to a posterior gastropexy, I think what they're just talking about is after pulling the fundus posterior behind the esophagus, there's just tacking stitches from that fundus to the median arcuate ligament and the crura. And I think that's very different than a hill repair.
Excellent. Any other questions, comments? Open the floor. Good. If not, well, thank you so much.
Dr.
Dr.
Benzie, can I just say one last thing? I think this is really, I love what you just said, because Dr. Benzie and Dr. Lee, you both know we actually are super conservative with reflux surgery unless there's an anatomic issue. And so we tend to do this only in patients where there's a displaced sphincter or where there's an associated para. And I just love to hear you say that, because you always kind of end up thinking that your thoughts are correct when multiple people say the same thing, right? So, I think this is great because, again, I think a couple of points over here. One is that a proper fundoplication is really critical if you're going to do it, because a failed one is the worst thing you could possibly do to anyone. And second of all, I do think at some point, Mike, will get to the EndoFlip driven closure or EndoFlip driven hiatal, out of a wrap or whatever you're going to do. So.
Yeah, I agree. I mean, there are people, I think of Steve Demeester, and I don't know if he's on, but I mean, he's somebody who really, he will say, we've already answered this question a few decades ago. You have to do a fundoplication. But my argument to him is when those studies were performed, we were not standardizing our crural repair. We now have with EndoFlip a device that can standardize our crural repair. And what I have been really surprised by is my inability to look at the crura and say it's tight or it's loose. there are times I look at it and I say, that looks loose, but when I measure, it's not, or vice versa. There are times that I think it's tight, but it's not. And I think that we now have something that tells us, you know, how tight it is without just subjectively looking at it. And so I don't know if those, I think we have to redo it, which is kind of what Christy is doing. We have to redo those studies now that we do have a standardization with that. And I think it'll be really interesting to see what we find. I think Christy's on, and maybe she can comment if there's any prelim results or anything that she can say about that.
So many things. Thank you, Mike. Happy to see everybody and great presentation. I'm just going to say one general thing. And I think that there is a heterogeneous population of people who have paraesophageal hernias. Some of them have an abnormal anti-reflux valve and some of them do not. And we looked at 30,000 x-rays a few years ago, and narrowed it down to criteria of people who had upper GIs 5 years apart since the 1980s. It was painful. And we sat in a room and we looked at all of the x-rays one by one to categorize the natural history. Now, it's not perfect, but we did find that there were plenty of people that seemed to have a paraesophageal pop out of nowhere. And then about 30% of them looked like they started out as a small type 1. So this is a heterogeneous population. And I think we need to move away from looking at, this is just about the valve and the fundo, and this is just about the crura, and this is just about the DI. It's not. We need to be better at figuring out these people. Now, you mentioned Steve. Steve is my long-term partner and my mentor, and you can imagine the fights that we have had. But even he has started to come around with, like, he still believes everyone needs fundo, but understanding that there is some heterogeneity in this, and it's a difficult topic. And I think that the flip is it's really helpful. But I caution everyone from going, just flip. Everything's about the flip. Everything's about flip. Everything's about crura. It is more complicated than that. And I hope we'll have some data for you shortly.
Yeah, I mean, totally agree. And I think that's really an important thing to end on. In the end, just like manometry or an esophagram or any other diagnostic tool, you can't rely on any tool completely. Like, it is a combination of different tests, and it's also the interpretation, and it's also, you have to take into account the individual patient. There's no question about that. And we do have to be careful about being very, strong in our statements about, it's all this or all that, or not this at all. That is completely true. And I do worry about EndoFlip, and I think I will say this right now. By the way, I didn't disclose anything, but I will tell you that I do not get paid by Medtronic for, the purchase of any of these catheters. I have given 2 or 3 lectures on it, and that's it. And I got a very small honorarium for that. I do speak a lot about EndoFlip, and I think it could easily come off that seem like I'm paid by them, but I'm absolutely not. But I will say that I am concerned about the education and the proctoring and training that the lack of with this device. So I think a lot of people are starting to become excited about it. And I think people are buying the device with minimal training. And I think that's a huge mistake, because I would say that it probably is not as complicated as manometry, but it is not something that you can just pick up and read a little paper and try to do it. Like, you need to understand the nuances of it. And I have complained to the company about that. And I think that hopefully something will be done about that to ensure that there's more training with it, maybe more proctorship, or they maybe more hands-on training that they can put together. But I am concerned, because there are times where the balloon is faulty. And if the balloon is faulty, it can be a subtle thing that you may not recognize. And in those cases, sometimes you can get numbers that you think are correct that are not correct. And you can really have a major problem. You could actually, in my opinion, hurt a patient just because there's a leak in the balloon, for example, or a sensor is off. And I think that our ability to recognize that, especially someone who's just picking up the device, is not there yet, and there needs to be more training. So we are pushing hard to make sure that there is more training with this, and that people really understand those nuances. And just like Christy said, I'd be very careful of putting all your eggs in the EndoFlip basket. Be very careful with that. It is a tool to help you, perform, I think, better surgery in the operating room, but it is not going to determine your surgery success by itself.
Yeah, and one more thing, Kevin, always self-promote. Your paper's great. It's in my
It's a
list.
humble addition to the literature that you guys have flooded. So
No, it's not
but it's
humble.
real,
It's
it's
great.
real life stuff. It's like the last, and I agree fully. And there definitely, if there are EndoFlip courses, and certainly we have some coming up, and Sages, you should look for those and get hands-on with this. I agree. Having the catheter is quite finicky at times. You have to be very delicate with it. You don't want to bend it. It can bend in the back of the throat, and so yeah, you have to be very careful with these catheters.
Excellent. Well, thank you all so much. It was a great discussion tonight. And also, part of it is having more fellows that go through complex GI surgery fellowships, because the more we train people to do this appropriately and the volume that you all have in your institutions, I think is extremely important. I know it was definitely for me too, because picking this up independently would have been really, really challenging. But anyone would like to be in our Twitter picture, if you wouldn't mind, please turn your camera on now so I can get a screenshot. Otherwise, great discussion. Thank you so much, Dr. Ojiki and Dr. Lee, for leading us. Dr. Jayaraja, always with your commentary as well, of course, and Pocket Squares. Our next talk will be November 11th, and it is on tips and tricks for Ira Lewis assisted esophagectomy or performed esophagectomy. And like I said, have a great night, everyone. And if you wouldn't mind, smile for the camera.